Thank you very much for the honor and Professor Yim for inviting me for this distinct lecture. It's actually been 4 years in the making. I was actually originally was invited in 2019, but unfortunately there are some events here around this campus which precluded me for some of you to even get to work. But then afterwards, when COVID pandemic actually set us back for 3 years, so it's actually a tremendous honor to finally step foot on CUHK to be able to do this. Randolph was right. Actually, I was born in Wan Chai and actually grew up there with my family. And I did my school up to Form 1 here, and then before moving to Toronto for high school, then went to Harvard for undergrad, and then did my medical training all in Toronto before I now been in New York for over 12 years. So as we said that, everything in life is about timing. And I think for me, it's been very fortunate for me in terms of timing that the evolution and the dawn of the transcatheter valve therapy and intervention actually just happened when I was graduating. There were actually no jobs for so-called cardiac surgeons interested in this field. But I think with the good timing, I was able to start a program at a smaller center around New York, and able to lead that and stay in the forefront, including instituting best practices. And then subsequently, Dr. Adams recruited me back at Mount Sinai in 2017. And so now been able to work with a world-class heart team to push the envelope. So without much further ado, I will actually talk to you about the evolution, how surgery becomes now catheter-based intervention in valvular heart disease. These are my disclosures. So our key objectives today is to provide an overview of how catheter-based interventions have transformed the treatment of valvular heart disease. And we're going to discuss how advances in imaging, as you know, surgery is also very heavy on imaging as well, has enabled catheter-based treatment of valvular heart disease. And I'm going to focus on three particular valves that are most commonly treated with this context. So a little bit brief history of those of you not familiar with structural heart. So in 2002, the first TAVI or transcatheter aortic valve implantation was performed. So recently, we just celebrated the 20-year anniversary. And then this year, actually, the first mitral transcatheter edge-to-edge repair was performed. So we got to celebrate 20-year anniversary here. And then, of course, after that, there were many first-in-human transcatheter valve, mitral valve replacement, tricuspid valve interventions, repair and replacement performed. And now in 2023, you can imagine there are over 2 million TAVIs performed around the world, over 200,000 mitral tears, over 3,000 tricuspid tears, and over 1,000 mitral and tricuspid valve replacement performed around the world so far. So clearly, it's a remarkable milestone in just the span of 20 years. Now, my journey with structural heart began around over 12 years ago. You can see that here. My first exposure was actually in Canada and Germany. I did a fellowship, brief observership there. I was in New York in 2011 when I started as part of the U.S. CUHK pivotal trial. And then essentially for the past 5 years after that, we built a program from the ground up. You can see that by the time I finished from that, we were on track to finish one of the highest volume in the area. And you can see that extremely successful with very excellent outcomes and many first-in-human procedures around the New York area. And then fast forward to my time at Mount Sinai, you can see that we have a full service line of structural heart program, over 500 TAVI, 99.8% are transfemoral, very few term access, O2E mortality ratio of 0.4, very low complication rates, and over 100 transcatheter mitral and tricuspid interventions. And myself, been fortunate enough to actually perform over 3,000 TAVI, over 600 mitral tricuspid valve interventions as well. Now, how did catheter-based intervention become so successful? Well, first of all, it's safety, right? As you know, safety is number one to our patient, but also it become clinically effective. There's been explosive growth of evidence in terms of the science behind it. Innovations obviously comes without that as well. And finally, refinement and standardization of techniques like what we see in surgery. And finally, advances in screening and procedural imaging to be able to enable these procedures to be done. The heart team evolution has also been critical. You can see that rather than just a cardiologist and a surgeon, we now involve a number of people, such as imaging expert, heart failure specialist, a dedicated coordinator, other physician consultants, anesthesia. So we now, all of them are now talking about patient-centered approach rather than just treating based on whether it's surgery or catheter-based. Now, the aortic valve, as you know, for those of you not in the operating room, has been quite calcified, typically a tri-leaflet valve. And this is Alan Crebier, a cardiologist, who actually treated the first transcatheter aortic valve replacement. You can see there here, actually what we call an antegrade approach, go looping all the way around from transeptal and exit the aortic valve in the aorta. And in fact, this patient was actually a bicuspid valve patient in shock, and that was kind of a salvage procedure, and he survived. Now, at the same time, since then, there have been a lot more devices and delivery systems being available. Number one, there are more sizes, being able to treat more patients. The vascular profile becoming smaller to be able to reduce the complications. There are now other ways to reduce the leakage around the valve. There are ways now to also reduce the risk of pacemaker and conduction issues. And finally, all these procedures and devices are becoming more user-friendly in terms of improving procedural efficiency and consistency. There are now two types of balloon expandable devices. One is in trial, one is approved by the FDA, and there are three different devices being currently performed in Europe and the United States from a self-expanding valve standpoint. And the approach has been multifactorial, but now mostly is transfemoral. And the next alternative access, we just did one today actually with the CUHK team, was a carotid approach, which actually demonstrated to be the best alternative access in terms of safety. Now, in terms of education, it's also critically important. There are a lot of manufacturer training and proctorships. There's fellowship training now available, hands-on courses by professional society. And finally, as we know, this is the internet age, a lot of online apps, and also to teach us how to do this without even leaving your own home. I actually created a YouTube channel. I think this is one of the best ways to teach people. You record your lectures. You can actually have your trainee watch the videos, rewind, do it multiple times, and actually in real time, learn it alongside with your own exercises. I think this has been tremendously successful, and we're going to continue this in the future. Of course, at the same time, every one of you here has a smartphone. So you can actually download any of these apps and actually for free and be able to learn and how to work up these patients actually right at your own fingertips by just looking at the images. And that's been done by my colleague and friend, a surgeon, Vinny Bapat, and my interventional cardiologist, Dr. Kinney at Mount Sinai. Now, what about the science? You know, you can't actually have a developed technology without the science involved. And you can see this is probably one of the most studied field ever in the valvular heart disease, with multiple large randomized controlled trials, not just short, but also long-term outcomes, large multinational registries, guidelines, society positional statements, and of course now extending to basic science. So you can see that here, just from first in human of a balloon valvuloplasty back in 1985, you can see that number of trials have been done in different valve types, and actually that's how we were able to get FDA approval more than 20 years ago, as well as an alternative device for the core valve. At the same time, the definition of how to run these trials have also evolved. You can see here with VARC 1, VARC 2, and now VARC 3. Now, the best indication of how many publications have been done, just look at PubMed, and you can see this is, I did it last night, and you can see that here over 15,000 publications have been done on just this TAVI field alone, and you can see over the span of almost 12 and 22 years. Now, TAVR in the United States and similar in Europe have been approved now for all surgical risk categories, and you can see that's based on multiple clinical trials to the extent that now both the US and the European guidelines have now indicated that for TAVR, if you're 65 or older in the United States, you can be done in a class 1 indication. In terms of the Europe, is 75 or older. Now, at the same time, the volume has exploded in the United States. You can see that, and actually, after 2018, the TAVR volume has superseded all aortic valve replacement completely. So anytime between root replacement, and also you can see the curve has completely diverged, and you can see that actually this year, or this year 2023, we extended to about over 100,000 cases. And you can see that here in terms of volume growth. At the same time, the age is patients are getting younger. And you can see that interestingly, this is part of Northern New England demographics. Is very eye-opening. Even though the guidelines says 65 or older should have TAVR, and 65 or younger should have SAVR, you can see that the number of patients getting TAVR, younger 65, actually going up, and actually younger SAVR are going down. So why is TAVR preferred over surgery? First of all, it's less invasive. There's no incision. There's no heart-lung machine. Most people go home in 1 to 2 days. 1 week, you're back to your own feet. You can do full activities. And of course, the randomized control trials speak for themselves. You can see that equivalent to surgery, 5 years in high, intermediate, and now low-risk patients, and superior to surgery in intermediate or high-risk patients with a specific device supraannular self-expanding valve in terms of hemodynamic performance, prosthetic valve dysfunction, and structural valve deterioration. Now, what are the hot topics in TAVR? You can see that there's bicuspid valve, coronary access for CAD, and finally lifetime management of these patients because you can see they're getting younger, not older. We know that there are over 50 stages of bicuspid valve, and you can see that here different morphology and calcification patterns. However, you can see that the trend is favoring TAVR. However, these patients do have a lot of comorbidities, as you see here. So how do we decide? So in surgery still have an important role. So younger patients, anatomy is suboptimal for TAVR. And of course, if you have aortopathy, which indicates that you need to replace the ascending aorta as well. However, there are patients who are considered higher extreme surgical risk. And if the anatomy is favorable for TAVR, they would tend to get TAVR over surgery. However, there are some issues involved. How do you size these patients? Are there leaflet and annular alveolar calcium potential risk for complications? Now, what about the behavior of the raphe itself? Can it be limiting the expansion of the valve and causing complications? And how would that impact durability? And finally, the evidence have suggested that bicuspid TAVR is associated with higher stroke rate and also higher pacemaker rate. So far we know that they do have favorable one-year outcomes in different types of valves. However, they are paravalvular more than trileaflet aortic valve, higher stroke and pacemaker rate, as I mentioned, and we don't know the long-term longevity. And this paper by Raj Makar and the Cedars-Sinai group show that if you have a more calcified raphe and leaflet, you actually have a higher two-year mortality compared if you do not have that anatomy, and you also have a higher rate of PVL. So clearly, this is not for everybody. Now, what about coronary artery disease? Actually, this is very enlightening because we see that in the clinical trials, over 50% of patients, even in intermediate risk, have concomitant CAD. And we know that even if you fix the valve, the CAD will likely progress. And the device access to coronary access vary from one to another. And so even as the cardiologists out there, they need to understand the device familiarity because most of them don't do TAVR, and so they don't understand what they look like. And because unlike surgery, the lateral aortic valve remains in place, and you have a stent frame in the way, and you do not have commissural alignment, so there can be some challenges to access the coronary. So let me show you two examples here. On the left side is a balloon expandable valve. You can see there's a big chunk of leaflet calcium shown in white here, potentially interfering the ability to engage the left main coronary. And you can see on the right side with a TAVR in a surgical valve, the left main is quite low, so the ability to try to engage that is going to be quite challenging because all these materials in the way. Now, we published a paper 5 years ago showing how anatomically and procedurally it had varied in terms of the different valves and how to impact coronary access. And now, as I mentioned before, our colleague Dr. Kinney and Dr. Sharma and I developed an app to actually video and tutorial to show you how to do this, even if you don't do TAVR. Now, why may commercial alignment be important in TAVR? Because coronary access may be relevant in taller valves. You might actually increase the likelihood of put another valve in by reducing the risk of coronary obstruction. This might be now impact on durability. And if you try to modify the leaflets of the first valve, it might not be feasible. Now, what does this mean? What is commissural alignment? Actually, surgeons do it all the time and every day. You basically align the commissures with the native commissures. But you can't really do that with TAVR until more recently. And you can see that we've now published a paper review showing that it not just had impact on this, but also have other things such as leaflet stress and also orientation, as I mentioned earlier. And now we actually might have techniques to actually improve the ability to align the commissures with these valves. Now, of course, these valves will ultimately fail because like all other prosthetic valve. And so you can see that the TAVR in surgical valve is on this rise, about 5%. However, TAVR in failed transcatheter valve is also on the rise, but right now still relatively rare, about 0.5%. But you saw that TAVR volume just going up, so we will see this percentage expect to increase. But what really depends on is the durability, is the patient's life expectancy. So you're 65 years old right now, you expect to live 20 years. 70, 15. If you're close to 80, about 10. If you're in the octogenarian, you're about 5 years. So it depends on when you get your first bioprosthetic valve. And so now the goal is try to get these patients to live to have the same valve till the 80s. This European Heart Journal review summarized very nicely about some of the post-sessional sequencing and the pros and cons in terms of how it might impact on the patient's longevity. It does the specific valve sequencing. You can see from 45 or older, and then by the time you're 65, you probably just have one reintervention rather than multiple. Now, how do we define valve failure? Actually, it has evolved as well from the surgical literature. Now, with cardiology, we now can say that there are different types. SVD meaning structural valve degeneration or non-structural valve degeneration, and we can actually characterize them different stages of valve failure. And depending on that, you actually have different modes of management. So you can see that within the last 3 years, the number of papers just focusing on valve reintervention after failed TAVR has exploded, and we've been contributing that in a significant manner. To such extent that we know how to work up these patients, and depends on the mechanism of failure, we now have potential treatment algorithm on fixing these patients. And of course, with new concepts and new intervention that comes with new vocabulary, we're now having to invent new terminology to educate these people out there of what we do, and nothing better, of course, than how to do it on social media and online resources to teach people how to work up these patients so you can do it in your own heart team rather than going to somewhere else as well. As well, we have now new tools to guide how to do this. We have sizing charts now being developed. We have a new app, as I mentioned before, that tells people how to do this right at their own home. Now, what if you cannot do a valve reintervention by doing an TAVR? Well, the only option is surgery. You can see that there's some pros and cons and factors involved in the development. And most cardiologists may not understand why TAVR explant is not the same as first or redo TAVR. Number one is that we actually remove the aortic valve in surgery, and we actually debulk the calcium, and so we have a clean tissue plane. And even re-op surgery, you still have a plane to work with. But if you have TAVR explant, you're stuck to the native anatomy, and you might be harder to remove it. And not just that, if you injure the adjacent structure, now you just convert a simple, potentially simple aortic valve replacement to a complex operation involving repair of the adjacent structures. And if you injure the aorta, you might have to replace the ascending aorta. So it's no longer an isolated AVR. And if you implant the valve deep from the get-go, unlike surgical AVR, you're going to have to potentially replace the mitral valve or fix the VSD. So this is not only a straightforward AVR. And you can see some of the intra-procedural operative pictures here. You can see how these valve extricators have, potential tissue ingrowth embedded into the aorta. And you can see that here potential different cardiac structures that could be injured as a result of removing these valves. And we actually have published, this is one of the first potential multi-center global registry looking at TAVR explant. And you can see the mortality can be quite high here in terms of 1 year, up to 20% as well in terms of versus redo TAVR. However, interestingly, after landmark analysis, it's no longer different. And you can see that here, this is one of our first registries showing a mortality of 30% at 1 year with TAVR explant. And whether you use one valve or the other, it doesn't really make a difference, unfortunately. And however, root replacement is as safe as isolated AVR. But if you have to do concomitant surgery, such as mitral replacement or CABG, then your mortality can almost 1.5 times higher, almost at 36% at 1 year. But of course, surgical techniques have evolved, right? With the surgeons getting more experience and now at excellent centers, you can see that root replacement now becoming rare. You can now use certain techniques to remove the valve and peeling it off on the native anatomy. You can actually extract the valve in different ways to avoid injuring the aorta. Of course, endocarditis is still an issue with these procedures. And mitral valve surgery with a previous TAVR can be difficult to expose. But mortality will improve with experience. And so there is now perhaps an impetus to refer to center of excellence rather than most surgeons doing one maybe in their lifetime. And we actually have recently instituted a workshop virtually on this. And you can see there are at least so many topics to try to learn and understand that we're still just early phase of understanding this field. So in summary, from the aortic valve standpoint, TAVR is indicating all surgical risk categories. But as you can see here, lifetime management is key. And in my opinion, high-risk anatomy in low or even intermediate-risk patients should still be considered surgery as alternative, especially you cannot do a redo TAVR. I think this is very important to tell your patients that if you do a surgery now, you can actually perhaps likely do a TAVR in the future. So you only need one operation in your lifetime. And you can see that coronary access and redo TAVR are the top issues in this field right now. And TAVR explant is a high-risk operation, but hopefully will improve with better techniques. Now, the mitral valve is much more complex than aortic valve. As you see, not all primary MR is the same. And you can see the guidelines here, surgery is still the gold standard in terms of surgical mitral valve repair. It actually restore your long life expectancy. Secondary MR, though, is different. You can see there's ventricular MR, meaning that there's leaflet tethering because of ventricular dysfunction, and you can see there's asymmetric versus symmetric. And now we know the new entity called atrial MR. What does atrial MR mean? It means you have long-term permanent atrial fibrillation. The atrium dilates, and as a result, you stretch the annulus and cause MR. And we know that these patients have high mortality risk over time, left untreated, but also they are very challenging in the treatment because you need to have a two-pronged approach fixing the atrial fibrillation, which is hard because they have permanent AFib and also the MR. Now, in terms of secondary MR, the TEER or transcatheter edge repair is indicated provided that you have favorable anatomy and on optimal medical therapy. And this is the same as the European guidelines as well. Now, of course, in the United States, you can see here the volume of transcatheter edge repair or TEER is continuing to go up, and the number of centers as well. At the same time, secondary MR, which is represented by the red bar, is continuing to increase because we see a lot more heart failure patients with secondary MR than those with primary MR, because primary MR, most patients should have surgery. Now, the mitral clip has evolved over the past 20 years, as I mentioned before, and you can see there are over 200,000 cases been done, over 60,000 people have been studied, over 2,500 publications, and a lot of global studies. Now, we can see that the advances have also, because the excellent safety, and now with more clips available, there's better imaging on transesophageal echo in terms of more standardizing, meaning that most images can reproduce this, and you can actually get a sustained in reduction. Now, the principle of doing this is you have to optimize the leaflet coaptation of how it's actually touching each other to maximize the MR reduction and also try to reduce the annulus size as well. So this is the mitral clip device. In fact, I was just in the cath lab with Dr. Kenso and the rest of the team doing one of these combined mitral and tricuspid procedure with this device. And now we have better understanding of what is considered contraindication for this therapy. And you can see there are a number of factors involved, or it's a straightforward anatomy or clinical picture to be able to do this really easily. But most of these patients in reality are in what we call yellow or orange, so it's more complex, requires some thought process involved. Now, for those of you who are not familiar with the mitral valve, this is what it looks like. That's the anterior leaflet. That's the posterior. You see a smiley face. In terms of the clipping strategy, we typically what we call go outside in to make it easier and also to avoid the device getting stuck. And we now actually have developed key imaging modalities. This is rather technical, so I won't belabor you in terms of the terminology, but you can see now only 3 bullet points rather than 10 different bullet points to try to get you to get the procedure safely. So just show you a quick case of a 72-year-old female. You can see this patient has cardiomyopathy, morbidly obese, and actually quite disabled, operated a walker. And you can see that here, one of the views that we look at is what we call a bicomical explain. This is a view to sweep the mitral valve, look at what the pathology looks like, lateral to medial, and also now looking at whether you can do the procedure easily by looking at the imaging anterior posterior. And you can see that with color showing the severity of MR. But of course, you can see you do a sweep, and I'm not going to belabor the technicality of this, so that you can actually do this systematically rather than just an ad hoc manner. We measure the length to see which clip to pick. And of course, now you look at the three-dimensional structure like we do in surgery in the operating room and be able to have a clock face kind of nomenclature so that, person A from person B will understand each other's orientation. Transeptal access is the key to do this procedure. And again, you can see a standardized view to look at how this is done. And this is by sweeping from top to bottom. And once it's done, you go to a specific to measure the height. Again, because it's a more general audience, I won't belabor the technicality, But one of the things that we now teach people is look at fluoroscopy as well to be able to show the distance and the relative anatomy can see what it looks like in terms of directionality as well. So when you actually understand fluoro and talk to the imager how that translates to echo, you'll be able to do the procedure much more quickly and efficiently. So once the device is across, you find ways to combine fluoro and echo to actually get the device down to the mitral valve, and you can see how this is done very efficiently by just looking one or two views. There's no fancy views you need to create, which of course you can if you have the expertise. Now, once you have the clip down there, you really try to get to this view to align with the anatomy, and you check your device, and then you go immediately to this view so that you basically catch the appropriate orientation for the anatomy that you try to target. And once you're done with that, you use fluoroscopy to try to help you to make sure you stay in a straight line rather than going sideways. And this is very important to be able to grasp the leaflet at the appropriate location. And so you can see that here on echo, that's how it correlates. You want to go straight down when going in the front versus the back, or being sideways, one or lateral or medial. And you actually have ways to actually check that. Now, in terms of orientation, you don't just use one more image modality. You actually use more than the fluoro as well. You take the parallax out, what we call basically one line, no arms being seen, and you come to the grass, you keep the same way, so you know that you're consistently having the alignment. And you can see this is how this is done, dropping the grippers here to grab the leaflets, and then when you close it, you assess the leakage and the anatomy, and you want to make sure it's right in the middle as you anticipated and planned for, and you check the gradient to make sure you don't cause stenosis. You check the vein flow, pulmonary vein flow, to check your forward flow rather than reverse flow, and then you deploy the device right afterwards under echo. And you can see that here, after the one clip only, you get a fantastic result with only trivial to mild MR. And you can see that here, this is what it looks like once it's deployed, with a tissue bridge between the anterior and posterior leaflet. And of course, you have to assess the atrial septal defect that you've created. The patient procedure, if despite all that images and slides that you've seen, actually we talk about 10 minutes because of the consistency that we now make it teachable to our fellows and trainees and other physicians or heart teams all over the world, and the patient can able to go home next day, which would be remarkable. Comes to looking at how you can treat these patients, and you can see post-procedurally very little mitral regurgitation to speak of. So in summary, at least with mitral TEER, mitral clip, you can see how far it's gone. Used to be a 6-hour procedure 20 years ago. Now it's only about 10 to 30-minute procedure. Extremely safe, image guided, and you can see that the key here with any of these procedures, at least the way I teach them, is to make it consistent, reproducible, and simple so that you avoid all the pitfalls and potential risks. I'm just showing some quick data from the Expand G4 registry, which we just presented at one of the biggest interventional cardiology meetings out there. And now with 1-year result, this is a Abbott-sponsored study, but it's core lab adjudicated, meaning it's not me or you looking at the echo. It's actually done by a group of experts, centralized, and over 1,000 patients being done. And you can see that it's not just straightforward anatomy. That's only about a quarter of them, but there are other anatomy that are more complex as well. So it's not cherry picking. And you can see that in patients with moderate severe to severe MR, at 1 year, almost 90% of them still mild or better. So now we don't talk about moderate or better. Mild or better is now, as surgeons would say, the acceptable outcome for any mitral valve repair, and certainly also for transcatheter repair. And you can see that in the case of secondary MR, like the case I showed you, is almost 95%. And if you look at the ones with complex anatomy, meaning it's not straightforward, you can see it's still 90% successful getting 1+ or better. So clearly it's come a long way. And you can see that here in this graph showing in terms of population of patients going mild or better. This is the original trial. Almost, you can see here 15, 16 years ago, you can see very poor outcomes. Only a third of them get a satisfactory result. Now it's almost 95%. So really now getting close to a surgical-like result, as I would call it. And it's not just because of that. Also, people say, well, what if you cause mitral stenosis? The answer is simply not true. At 1 year, the gradient remains stable. It's very acceptable. And also the all-cause mortality at 1 year, even with secondary MR, usually these are high-risk patients, is still acceptable around 15%. And you can see the outcomes also better. Why? because we know how to better select these patients, because we know the procedural safety is there, but we also need to make sure they have the efficacy. Now, there are two current randomized control trials being done for primary MR patients in lower risk. So the first one is Abbott-sponsored, which is intermediate risk, and you can see 75-year older in general, and patient with 10-year follow-up. And you can see the primary MR fund was NIH funded, and there's a younger patient called 65 or older, any surgical risk, and these are randomized patients with primary surgical mitral valve repair versus mitral clip or other approved commercial device. So this could be a very interesting trial because you can see mitral clip with TEER now has 95% in expert hands, 1 year mile or better MR, and we'll see with surgery can match that the same way. So in summary, in primary MR, TEER is now indicated in high and prohibitive risk patients only. But in secondary MR, TEER in suitable patients and favorable anatomy will pretty much be the default therapy because surgery just do not have the same outcomes. The latest mitral clip device, as I mentioned before, has different sizes to customize the repair. There's also another device called Pascal, but I'm not going to describe it in the interest of time. And you can see now new randomized trials looking at low risk patients. Now, there are other newer technologies as well in the repair space, not just edge-to-edge. There's coil replacement. There's different companies getting involved now. There's direct annuloplasty, but it's shown to be technically very difficult, so we haven't quite made headway. There's indirect annuloplasty or ventriculoplasty, but these are more for heart failure patients. In fact, there's leaflet augmentations as well, but they now still have anchoring issues. So these are still kind of in the early phases of development. Now, having said that, there is a replacement solution in the horizon for these patients who might not be a candidate for repair. So how do you decide this? Because now with repair solutions available. So first of all, can you reduce the MR to 1 plus a mile better? If the answer is yes, you always do repair. That's like what surgeons would say, you prefer repair over replacement. However, if the answer is no, then you have to ask that the patient take anticoagulation because that's one of the requirements for a replacement device. And of course, the anatomy have to be suitable, and this is one of the current challenges. And so right now, most of the devices are geared towards transeptal because it's less invasive versus transapical, but there is a transapical device that has been approved by the Europe right now. So you can see all these devices look very different. Why? Because they have different anchoring mechanism and they have different approaches. But you can see that here the screen failure rate is quite high. You can see that over 70% in this multi-center trial that I was part of. And you can see one of the biggest reasons is that the sizing is an issue, but also the LVOT obstruction risk is also another issue. So the other also reason is that we have a commercial device available. We can just get it off the shelf and treat the patient. With a trial, you have to do all kinds of diagnostic workup, so a lot of these patients do not want to go through the process. And also, transapical approach in these patients is really a deal breaker from the patients and family and also from the heart failure cardiologist because it's more invasive and they just don't do well when you already have reduced ejection fraction. Almost all of them require warfarin as a primary mode of anticoagulation, and we still don't know the durability. The risk of LVOT obstruction is multifactorial. We can see it because the device sits right here. You can obstruct the outflow, leaving the outflow tract to the aortic valve. But also, the final position can be unpredictable. You can basically shift one way or the other. The geometry itself can change. You know, the area, what's the real cutoff, you know, between you or me, it might be different, and what is the highest grade that can be tolerated. So I'll show you just one particular example. This is about that we have the clinical trial experience. Right now, you can see there's a trial that is a single arm, it's no longer randomized. There are two different cohorts. One is just a regular group of patients. The other one is called mitral annular calcification or MAC. And you can see MAC, what does it mean? That means these are people with heavy calcium around the mitral annulus. That makes it challenging for surgery, but also challenging also for replacement. And so this is a presentation that was done just now, 1 year looking at the early feasibility. As you can see, the safety probe is excellent in terms of replacement. These are very big devices, but still you can see 1 year mortality is only 6.7%. But the beauty of this platform is that there's no MR. It's MR elimination, not just reduction. You can see 100% of these patients have no leak at all, and even 1 year has very few transvalvular leak. Gradient remains stable. It's not they cause stenosis. The valve remains durable. and you can see the recent publications. Now, what about longer-term outcomes of these devices? So this particular platform has also the same thing. This is now 3 years out from a transapical approach. You can see, again, MR elimination, not just reduction, and the gradient remains stable at 3 years, so certainly very encouraging. And also you can see that there is some LV remodeling as well, particularly end diastolic volume. Now this device has now evolved to a smaller profile. As we know, small profile is better for the patient, and I think in general, and this will start in the trial next year. But the challenge with these trials is that how do you decide repair versus replacement? Because now MitraClip is actually approved. There's a high screen failure rate due to the anatomy, so it's very discouraging from a site to try to keep enrolling these patients. We know transapical access is not ideal, and also transeptal access is more promising, you saw, but certainly needs cut down, but we are evolving to more percutaneous strategy. The reduced ejection fraction and need for anticoagulation remains to be Achilles' heel, and so we need to look at the implications of this. Now, in terms of finishing the mitral valve topic, I need to show you MAC. What does MAC mean, mitral and classification? You can see this also like bicuspid aortic valve more than 50 shades because they all come at different anatomy. And there are now papers looking at how do you manage these patients. Because now that we have heart team and valve clinic, suddenly these patients come out of nowhere and just been populating our clinic consultations just to be able to figure out what to do with these patients. And now we're trying to finally be able to figure out some management strategy because they not just have coming with mitral regurgitation, they come with mitral stenosis or mixed etiology. These are typically small female with hostile anatomy. They often high surgical risk. And so there's a lot more to be known about these patients, particularly potential interference of the anatomy with these percutaneous devices. And so in terms of the stenosis versus regurgitation, the management strategy will be different. If it's mitral, something happened to the screen. If it's stenosis, it's going to be more likely replacement, but if it's regurgitation, it's going to be more likely repair, maybe replacement. And we published a paper on how to manage this patient based on the Mount Sinai approach. But you can also do actually edge-to-edge repair, but you have to be mindful of some of the anatomy in terms of risking stenosis, what kind of clip can you actually put in, and also the risk of SLD, meaning device detachment and stenosis. But most of the time, we will replace the valve either surgically or maybe a hybrid approach. And this it depends on the screening criteria, as you see here in this paper. So I'm just going to quickly show you a surgical video in the interest of time. So we first remove the anterior leaflet. Why? Because that is what causes the LVOT obstruction. So now we have the sapien-free balloon expander valve, and we actually sew a Teflon felt, almost like a cushion to reduce the paravalvular leak and also reducing the risk of AV groove injury. And after we sew that in, essentially, you can see that here it becomes a bulkier valve, and kind of like what we do in surgery with a surgical bulky platform to sew onto. And then we basically put this valve directly across the MAC anatomy. And you can see that here we expand and deploy the valve with a balloon. And then we test the valve, and you can see actually at the end, it almost looks like a surgical valve, but you just put it with just very few sutures, and you can see that here, just to avoid migration. Of course, these devices can still cause LVOT obstruction, paravalvular leak, migration embolization, and AV groove disruption. So it's not a foolproof concept. So whenever possible, we still like to do conventional mitral valve replacement. Now, there are anatomies that you could potentially do it percutaneously, and this is one example. You can see very nasty mitral regurgitation and MAC with mitral stenosis. And you can see that here we work up the patient for this Intrepid Medtronic valve. You can see the calcium there. You can see the LVOT obstruction risk here. So this is all worked up a priori. And this is the valve deployment. It's a self-expanding valve. You can see that here. You go from the groin and down to the apex and the ventricle, and then you remove the device. And you can see initially there is some central MR because of the deformation. But over time, these will get resolved. As you can see that here, trivial MR and no potential issues at all. However, these patients may not live long enough to benefit this therapy. You can see this is part of the 3-year, 5-year mitral trial. You can see the survival is only about a third of them. So it's clearly pretty poor prognosis overall in this group of population. So in summary, in terms of TMVR, you can see that the offers the promise of MR elimination and with reasonable good 3 to 5 year data. But you can see it's just a lot of workup required to make these patients through and get the procedure done. The high screen failure rate is a concern. It's mostly device driven, and of course, there's still a number of unknowns warrant longer term studies. Finally, the tricuspid valve, it used to be called a forgotten valve, but no longer is it forgotten because most people now recognize if you have severe TR, whether you're asymptomatic or symptomatic, it's bad for you. Survival and hospitalization are poor. However, most surgeons do not operate on the isolated TR because they are considered high surgical risk. You can see here only about 0.4% of these patients are being done. Why? Because there are a lot of sickness. They're either advanced renal and hepatic dysfunction. Then these patients have bad RV, and you know bad RV is the enemy of any open cardiac surgery because you can have acute RV failure requiring ECMO and high mortality, and organ dysfunction, acute liver failure, bleeding, and mortality. And finally, a lot of these patients are reoperation. They're not first-time surgery because they're previous mitral valve surgery. Because of that, there are now lots of devices being developed. However, most of them have fallen by the wayside, and not many are left in terms of being clinical trials. A lot of papers have published in the last 5 years on tricuspid valve. First of all, imaging. Imaging is key to be able to do this properly because the TE probe is away from the right side of the heart and esophagus, so it's hard to see the tricuspid valve. We also know that there are different grades of tricuspid valve 5, and actually we call a 6th one called tsunami because it's that the valve is completely blown open and you can't really have non-functioning valve. We also learned that the tricuspid are not just 3 leaflets, they're actually a multi-segment, up to 5 leaflets and 5 segments, and the 4 segments tend to actually be quite common. And if you have 4 or more, actually it's harder to do and you're more likely to have residual leak after transcatheter intervention. Of course, the imaging is required, and as I mentioned earlier with the mitral tier, tricuspid tier, you also have a set of imaging that require on echo, and we can actually classify this in terms of similarly green, yellow, and red category based on anatomy that I've developed here. And also you can see some of the anatomy that evolve in terms of what's the straightforward case on the left versus the right is usually much more difficult because you don't have the leaflet to grasp safely. Now, having said that, there are some advances in imaging. What you see here is basically a tricuspid of the clip, like we did earlier with Ken and the team. And you can see that also intracardiac echo to avoid some of the potential handicap with TE imaging to be able to see this better, to be able to do the procedure safely and effectively. The TriClip device is approved by, is made by Abbott, and David Adams recently presented the overall trial result from TriLuminate that Randolph has mentioned. This is a randomized controlled trial, first time of a TriClip versus medical therapy. There's also a single arm in terms of difficult anatomy. And this paper that I was part of in the New England Journal publication show the primary endpoint has been met. We also look at now the entire cohort of patients got randomized. And you can see that here, when you get the TriClip, 88% of the time you can get moderate or better TR, which is the endpoint. However, at the same time, when you test them objectively, how far and how long they'll take to walk, if you TriClip, you actually also be better. Now, we also look at the patient with difficult anatomy on the TriClip device, 100 patients because there's single arm. And you can see that these patients are definitely more complex with more ventricular ventricular lead and more aortic mitral valve intervention in the past. Why is this relevant? Because you can shadow the valve in terms of making imaging more difficult. And you can see these patients have more torrential TR, bigger gaps, bigger hearts, and bigger annuli. So all in all, they're more difficult patients. However, having said that, the procedural time is not that much different. Most of them do go home. Length of stay is not worse, and most of there's 0% mortality, which is very important. And you can see that this procedure is extremely safe, like the mitral clip, and also the risk of device detachment is around 7.5%. And 1 year, the TL definitely can be sustained in terms of single arm, which is the more difficult anatomy, at 81% versus randomized trial, nearly 90%. However, these are sicker patients in a single arm. You can see mortality is definitely nearly double, and hospitalization also almost double as well. However, what does KCSK? This is what we call quality of life metric. This is now a very common metric we use for randomized trial in the structural heart world. Look at patients' quality of life by asking them a questionnaire, and you can see that by going to the bathroom less frequently, be able to sleep at night. I mean, those are very important quality of life. Be able to walk without carrying extra 10 pounds of weight on your body. So you can see that with this therapy, certainly it improves over if you do nothing. Now, not just in terms of quality of life or heart endpoints, this actually happens also when you look at CT MRI studies, looking at if you look at the heart, it shrinks, and nothing better than show you look at visually. Look at the case on the left side before and afterwards. 1 month, this is not like I doing Photoshop to make it look smaller, but this is real. You can see the RV actually reduces in size and in volume as well. And you can see this is strongly correlated with the ability to reduce the tricuspid regurgitation. And you can see that also here, the forward ejection fraction also improves significantly. These patients do feel better because now there's more forward flow compared to before. So in terms of tricuspid tier, in the summary is that the screening is the key and patient selection is key. The now newer imaging modality can help reduce the procedural time and also improve outcomes. However, there are some conflicting data that we need to answer, but of course, it's only 1 year. We need longer term to answer these questions. And finally, I think getting the TR to moderate or better is essential to will get you clinical and functional outcomes. Now, what about replacement? Yes, there are devices right now. There are 3 devices under development, actually one from China. And you can see that this is one of the randomized trial here of this particular device called Evoke, made by Edwards, and about 3 different sizes. However, you can see that here there are some comorbidities associated with this patient, high stroke rate and high pacemaker and previous surgery. However, these patients do not have as much TR as the TriLuminate trial, only about 55 to 58% compared to 70% in TriLuminate. And of course, with replacement, what do you expect? TR elimination. You do not see TR here. You can see at 6 months, almost all of them had no significant TR. And you can see, however, there's a trade-off replacement. The device time is not bad, about an hour. It's a little faster, but there is a risk of conversion surgery, and your hospital stay is going to be 4 days at an average versus 1 day with TriClip. Not just that, mortality at 6 months, at 30 days rather, is not 0, okay? And also because of severe bleeding, cardiac complication, and more importantly, requiring permanent pacemaker, which to this patient may not be a win for them because we know that chronic RV pacing doesn't help the right ventricle. Then there are also some unknowns, paravalvular leak, lead management, migration, thrombosis because you're on the right side, acute RV failure requiring resuscitation, ICU stay because of TR elimination, and also can the RV remodel in a favorable manner, and also maybe some unintended consequences. Now, going back, when do you actually do surgery for tricuspid valve? So I think if you don't have good anatomy for any transcatheter option, I think surgery still needs to be discussed, especially in operable patients. And these are patients with very tethered leads, with previous tricuspid repair, or patients who are not amenable for transcatheter therapy, for example, congenital endocarditis or rheumatic. So in summary, the tricuspid valve, you can see here, is gaining momentum in clinical studies. Early results are promising. There's some positive remodeling, but it is limited to more favorable anatomy, small gaps, no leads, a good imaging quality. I think anatomically, annuloplasty is more complex to do, but it is more surgical-like in nature. And replacement, yes, it might be simpler, but there are some unknowns, especially pacemaker rate, thrombosis, and need for preemptive management of these patients ahead of time. So overall, I think catheter-based intervention in just a short 45 to 60 minutes of lecture, you can show that it's really transformed the treatment of valvular heart disease over the past 2 decades. And you can see that most patients now, and more of them, can be safely, effectively treated, especially when back then when surgery is the only option, and now you have a complementary solution. Advances in technology and technique, training, evidence continue to push the treatable limits of these devices. And of course, because of the explosion of transcatheter therapy, re-intervention for failed procedure is going to grow. And surgery still remains a vital role in patients with suboptimal outcome expected with catheter-based interventions. And of course, finally, there's a huge unmet clinical need in underserved population. And so at the end of the day, we need to raise the awareness of these therapies available and to be able to democratize the valve treatment in these patients who consider high risk, who might not even be aware this option will be available. And finally, multidisciplinary heart team collaboration, I think, are key, such as the one you have in your institution, to be able to offer the entire spectrum of management strategy to our patients, not just medical therapy, but also surgery and catheter-based interventions. And on that note, I have to thank you again for the honor for having me here, and I thank you and welcome any questions.
Thank you very much, Gilbert. I think we all have a tsunami of information that Gilbert have poured to us. And is there any question? Professor Yim, please.
Randolph. Well, thank you very much, Professor Tang, for coming to Hong Kong to share with us your tremendous experience and wisdom in this evolving field. I guess it is not customary for a donor to ask questions, but anyway, I will. I'm specifically interested in complications following TAVI, and you alluded slightly to that already about the strokes. I would like to ask you what has been done recently to try to cut down on the postoperative stroke rate, as you know, because it's terrible, really, for patients. I asked this question because I lost a very good friend of mine 10 years ago.
Yeah.
As you know, Tom Ferguson. He was a very, very close friend to me. And I remember when Carol Blasberg called me, it was terrible. Anyway, I just want to ask you about the strokes.
Yeah, no, that's a great point, Professor Yim. And actually, this is still one of the conundrums facing it even up to now, 20 years after the first TAVI was done. I mean, there have been some improvement for a number of reasons. Number one, we're doing transfemoral, that these systems are more flexible to stay away some of these aortic arches that are very atherosclerotic and calcified, which can risk stroke. And number two, the device profile are smaller. So, and actually, and finally, now we have a device that is approved to protect cerebral embolic protection. That's the general terminology. But the device that actually place filters into the innominate artery and the carotid artery to try to trap these debris that can generate from the procedure itself to reduce the burden of stroke. Now, having said that, people study, well, where did these stroke, where did it come from? So actually, they're multifactorial. So number one, we didn't take out the aortic valve. So there can be debris just from aortic valve tissue alone. Or when we do wire exchanges, you can actually some intimal tissue that we see. Then, of course, there's little debris from the catheters themselves, little like a foreign body. And of course, there's some thrombotic material that can actually develop. So it's actually, we can't say, well, we can exclude everything, altogether. So even we have filters, and now there's some other filters being developed that can deflect it. So rather than capturing them, they they put a little kind of umbrella-like filter across the aortic arch to bounce them off afterwards. You can capture them, and they go downstream. In reality, it only protects you during the procedure. So what we found already is that atrial fibrillation itself is the single most important predictor of stroke, irrespective of whether you have baseline atrial fibrillation or post-op atrial fibrillation. So we are really trying to understand what kind of anticoagulation strategy we can to maybe even minimize the stroke in these patients, because this is the biggest population. Over 35% of patients have baseline atrial fibrillation in patients undergoing TAVI. So right now, what we try to do is to stop their anticoagulation, 24 to 40 hours beforehand to minimize the gap that they're off anticoagulation. Of course, we cannot just continue because there's a bleeding risk associated during the procedure. But we also try to immediately institute the anticoagulation again, either the same evening or the next morning to minimize the gap. Because at the end of the procedure, even though we give heparin during the procedure, we still have some partial reversal with protamine to offset the risk of bleeding. So that is why we're so particular about making sure we have no vascular access issue, because if you have, you cannot resume the anticoagulation. And then finally, I think we always tell the patient, yes, we can put in these filters and these fancy devices to protect you during the procedure. But after the procedure, 24 to 72 hours, you're still at the mercy of potential debris embolization that you cannot, protect. Even you have normal sinus rhythm, because you just cannot predict that who will get that. In fact, there's some patients we knew that would be high risk stroke, walked away home, no problem. And those we did not expect it at all. And then even despite protection, suffered disabling stroke. So what we, I think, trying to really determine is how do you reduce disabling stroke, because those have the highest mortality. And everyone will tell you, every patient will tell you that I'd rather be dead than have a disabling stroke. So that is still something that we cannot overcome right now. And I think this is the same thing for cardiac surgery as well, to be fair. I think, Randall, would you agree in terms of even cardiac surgery, trying to reduce stroke rate is still, we don't have a golden answer. So let's see what we try to do, some medical management to help maybe maintain certain cerebral perfusion pressure. So it's very interesting. We've seen some people with stroke-like symptoms just because the patient have a little bit hypotensive and suddenly they feel like, certain deficit. But when you bring the pressure up again, they suddenly disappear. So I think there's certain patients after aortic stenosis is treated, they need to recalibrate their blood pressure to be a certain range. And of course, if you're, super hypertensive, they can also risk embolic events. So I think even post-op management can be quite critical in making sure these patients. But I hope I answered your question.
I think it's a PhD defense standard. So, Ken.
Thank you. Thank you, Gilbert, for your excellent lecture and also coming to guide us to the three very interesting cases, TAV in TAV, mitral tricuspid, and also a transcarotid TAVI, all very successful, and we will learn a lot from you. So further to the lectures, I have two questions for you. The first one is on the future development of TAVI. So we know the TAVI result has been so good. So, but there's still an issue with the durability of the valve when we expand the treatment to younger and lower surgical risk patients. So how do you see the future? Is it going to be some, for example, like the percutaneous mechanical valve implantation, or some synthetic material is going to be developed? So that's the first question. The second question is, we know the transcatheter edge-to-edge repair in mitral and tricuspid has been so promising because of the high safety profile. But as in the surgical counterparts, they always, open heart surgery, they always has an annuloplasty wing. Do you think a percutaneous annuloplasty wing still has a future? Or even a transcatheter valve replacement is going to take over the future? Thank you very much.
Yeah, thank you for your question, Ken. It's been great to be here to work with you and the excellent team to be able to do this complex procedure relatively easy. I was blown away and very impressed, and thank you for having me be part of this group. Your first question about TAVI. Yeah, actually, there's a lot of material science being developed. Obviously, the holy grail is to develop some kind of synthetic tissue without any lifelong anticoagulation, right? We have always tried to do that mechanical valve. We developed new mechanical valve, but still that is stalked by potential thrombotic event. So yes, there's some devices being developed right now, but it's still very early, and it's still challenging because there's so much redundancy with the body's, anticoagulation and antithrombotic pathways. That's very difficult to try to suppress all of them and successful with time. So I think tissue valve is still going to be the future for the foreseeable future. Having said that, tissue science has also developed. People are trying to understand why tissue valve fails. So hopefully they'll evolve as well in terms of trying to develop better tissue processing. But in terms of being able to perform, as you mentioned, lifetime management is going to be very important. And the reality is that the design is to change to be able to facilitate that. And right now, I think most companies, unfortunately, are stuck to their current design, having not been able to think outside the box, because when you put in a transcatheter valve, you have to balance between, not much material to be in the way versus the radial strength to be able to maintain the shape and the geometry to reduce the leak, to be able to sustain that over time. And so I think that is still a lot of R&D to be done in the future. So definitely the final chapter has not been written. In fact, it's just the beginning. But certainly, I think at least in majority of patients, in elderly patients, this is an excellent option, especially for them to be able to go back to the better quality of life. To your second point about mitral and tricuspid, I think the thing that really going to be a concern for replacement is the anticoagulation piece. Most of these patients have bleeding risk underlying, and the reason why they're either not on anticoagulation or they on these DOAC that can be just taken orally without having to reverse or check the iron out. And especially with the right-sided system where it's more prothrombotic because of low pressure system, it might even be more prone to that. So annuloplasty, yes, it'll be a holy grail, but as we know, there have been annuloplasty solutions being developed, but they are limited by two things. One is the anatomy is not that easy because remember, the mitral is not a flat structure, right? It's actually a more saddle shape. Obviously, flat now with dilatation, but it's still, you have to try to put a ring in a three-dimensional shape, and you can't just do it at the same time. You have to do it sequentially. So imaging has been one of the main reason why we haven't been able to do it more systematically and easily because it's hard to see. So once hopefully imaging improves, like ICE, for example, the four-dimensional ICE, and also the device make it a little more user-friendly, and I think they're now under development, I think there will be a solution on the shelf eventually, and that will probably likely be the first-line solution if you can be as safe and as effective as TEER right now. And because also the reason for doing that is that you set yourself up as a staging platform for other solutions. What I mean, you can actually still do TEER. Addition might be easier because now the gap and the anatomy is more favorable, and you can put a replacement inside the ring that you built already. So like a docking station, similar to what's been done already in like a mitral valve in ring, for example. So it actually has potential multiple benefits. And some of the replacement devices right now actually are premised upon this kind of concept, but still, it's still a few more years away from being reality.
Thank you. Any other question? Oh, last.
So since, Gilbert, thank you for an excellent lecture. So since the TAVR results are so good and, we're expanding the indication to very young patients. So just let's say I need the TAVR tomorrow or something. So I need a aortic valve replacement procedure for tomorrow. So according to what you advocate, will you recommend me to have a TAVR, a surgical prosthetic valve, or I should stick to the guidelines right now, having a mechanical TAVR? So what's your thought on that?
Well, I presume that you are younger than age 65. No, but all kidding aside, someone like young patient like us will recommend the Ross procedure and we will send you to a center of excellence like ours because that is the best valve substitute, right? That's nature. And we now have 20-year durability. That's just recently a number of papers published that is better survival and actually restores your life expectancy, better survival than mechanical or tissue valve. Now, if you're not candidate for Ross, if you obviously want to avoid anticoagulation, the only option is prosthetic valve. So the question is, what down to is the CT anatomy. Number one, can I get an optimal valve sizing for you that will confer the optimal durability, meaning that it's not going to get scrunched up, it's going to be properly expanded. Number two, it's going to avoid what we call prosthesis patient mismatch, meaning your anatomy is going to have a too small valve for you, so when you exercise, you're going to be actually causing functional stenosis. And the third is whether if we kind of put a TAVR in right now, can we put a second one in the future? And often you can predict that already with the CT scan and look at the anatomy. So if you cannot, then we might argue that maybe surgical valve replacement with a root enlargement and making a big valve for you, then you do a TAVR in the future because we know surgical aortic valve with a prosthetic valve in someone like yourself will probably last at least 10 to 15. And actually, we've been pleasantly surprised that some of them last even 20 years. So essentially, you only have one operation in your lifetime, potentially. So that's kind of the heart team decision making now that we do on a daily basis.
So you think that the mechanical aortic valve is almost obsolete, or
no, not at all. Because remember, there's not a lot of Ross experts out there in the world, right? And most people would be willing to, if they're not willing to go for another open heart surgery, you really have to kind of commit yourself to mechanical prosthesis with the understanding that you're going to have commit yourself to lifelong anticoagulation to avoid some of the sequelae. But from a quality of life standpoint, it's very difficult for a lot of these patients. And we don't have a holy grail of low iron out threshold or maybe DOAC to be able to do that yet. So we'll see what the tissue science and the material science lead us, I think. Unfortunately, nothing right now that I would say that is perfect for most patients in terms of most surgeons are not just be able to replace the valve with any prosthesis.
Any last question? I think the time is almost there. So if not, maybe another round of applause to Professor.